Okay, class. So this is the second video, and I do have it starting with active transport here. This is a way that our electrolytes move across a semi-permeable membrane. Uh, Generally, we think about this with sodium and potassium. And so it is important, and we're going to talk about a little bit more here coming up, that we understand that intracellular fluid is primarily made it has a much higher concentration of potassium than the extracellular fluid, and that sodium has a much lower intracellular fluid concentration that does extracellular. So we have to use energy in order to move those against the concentration gradients so that extracellularly we can have sodium be where it should, and intracellularly we can have potassium be where it should. So this is another pictorial representation of that. You have the sodium potassium pump trying to put potassium into the cell and push sodium out of the cell, even though it is naturally, kind of going the opposite direction in order to um, equalize the concentrations on each side of the cell membrane. So that pump requires energy in order to keep sodium and potassium on the sides of the semipermeable membrane that they need to be on. So we're going to be talking a lot about fluid balance. This is going to be extremely important. And I apologize, my dog is joining in, but it's closely linked to affected by electrolyte concentrations. So as we talk about fluid balance, a lot of what we are going to be discussing is um, is our electrolyte concentrations as well. And you will see that that gets specifically into dehydration and overhydration. So obviously our fluid balance is going to be affected by fluid intake as well as fluid loss. So generally we need about 400 to 600 milliliters a day to remove waste from the body. Now just remember that we learned the very specific one of 0.5 milliliters per kilogram per hour. So that is, specific to the individual person. The 30 milliliters an hour or this 400 to 600 milliliters a day are just kind of general rules of thumb. If you have an individual patient, we need to use the more specific one. And then we also have insensible water loss, and this is important. It goes through the skin, it goes through the lungs, it goes through the stool. And so you have to stop and think about patients that are going to be more affected by this. So patients who are extremely diaphoretic, who are very short of breath and are breathing much faster, they have asthma, something like that. Stool, if they are having a lot of loose stools, diarrhea, all of that is going to affect how much fluid that somebody loses and therefore affect their fluid balance. So we also have hormonal regulation of fluid balance. We've talked about the renin-angiotensin-aldosterone system, and we're going to talk about that a little bit more. The antidiuretic hormone we've also discussed, so that does help us hold on to, fluids. The natriuretic peptides we haven't talked about as much. You will be talking about those a little bit later in some of your other courses, so I'm not going to hit on that one as much here. So the significance of fluid balance, the renin-angiotensin 2 pathway, which we have talked about. So in our blood, volume intracellular fluid is most important to keep in balance. We need to try to make sure that our plasma and our intracellular fluids are balanced out, and that our kidneys do a large portion of that sodium and water balance. Um, we have to have that balance in order for perfusion to get to all of our tissues and organs. So when the kidney sends a low parameter, they secrete renin. So renin comes from those juxtaglomerular cells, and that starts off the renin-angiotensin 2 pathway. So it is stimulated when in shock or when there's a stress response as well. And then remember that I'm going to go through the whole pathway again here in just a moment. But remember also that ACE inhibitors, so when we talk about blood pressure and things, those ACE inhibitors disrupt the renin-angiotensin 2 pathway, reducing amount of ACE that's produced. And when we have less angiotensin 2, less vasoconstriction and reduced peripheral resistance happens. So we don't have the peripheral vasoconstriction, and therefore that's one less way that we increase blood pressure. There's going to be more water and sodium in the urine when ACE inhibitors are taken. And they can also block the angiotensin 2 receptors. Those are actually called ARBs, angiotensin 2 receptor blockers. And so they help lower blood pressure. So they take patients with hypertension often take these ACE inhibitor medications. So if this is a little confusing right now, I think within the next couple of slides, it'll make a little bit more sense. Okay, so here's antidiuretic hormone and what it does. So it will notice that there's an increase in blood osmolality, and those receptors will stimulate the posterior pituitary to secrete antidiuretic hormone. Antidiuretic hormone increases the distal tubule permeability, and so therefore we reabsorb more water into the blood. And so urine output goes down. We're holding on to more fluid, and so the serum or blood osmolality decreases as the water dilutes body fluids. So as we hold on to more fluid, the osmolality, or you can think about that as just the concentration of the blood is going to go down. Now, when we have a decrease in osmolality of the blood, the antidiuretic hormone is suspended, and antidiuretic hormone causes the distal tubules to become less permeable, so we don't absorb as much water into the blood, and urine output can go up and osmolality can return to normal. So it's a regulatory system. Cash, leave. So again, as promised, here's the more detailed version here. So yes, we have hormonal regulation through ADH, which we just talked about, but here's the aldosterone, the renin, angiotensin 2 system. So when we get that renal ischemia, when there's not as much blood going to the kidney, so if blood pressure is low for some reason, we have the renin is secreted by the juxtaglomerular apparatus, okay? It combines with angiotensinogen in the circulating blood that is produced by the liver, so it's already in the blood, and the renin combines with it. That gives us angiotensin 1. Angiotensin 1, when it circulates through the lungs, becomes angiotensin 2 because of angiotensin 2 converting enzyme. So that's one way that an angiotensin or an ACE blocker would work. It would decrease that converting enzyme in the lungs and would not allow angiotensin 1 to become angiotensin 2, or not as much of it at least. Angiotensin 2, it goes to the arterial smooth muscle, causes peripheral vasoconstriction, therefore increasing blood pressure, decreasing renal ischemia. Angiotensin 2 also causes aldosterone secretion by the adrenal cortex, which specifically causes sodium and water retention, which is going to increase blood pressure. So the other type of medication that can be taken is an ARB, or angiotensin 2 receptor blocker. And so that is also going to, it's going to block the process after angiotensin 2 is created, but it's going to block the receptor so that it can't go to the arterial smooth muscle and cause peripheral vasoconstriction, or cannot uh, go to the adrenal cortex and cause aldosterone to be secreted. So both of those types of medications decrease blood pressure by blocking this particular mechanism of action. So some things to keep in mind is that oral fluids, these are average daily intakes. So this is just what the typical person takes in: 12 to 1500 milliliters in fluids, 1000 milliliters in water. And then they have kind of a metabolism of water as a byproduct of food of about 200 milliliters. Uh, this is just an average. Just keep in mind that when our patients are have low fluid volume, that we definitely have them increase this amount. So let's talk about thirst. So there's different ways that our thirst center can be stimulated. So we can have a decrease in plasma volume, so blood volume is down. We become thirsty if there's not enough potassium. Psychological factors: you see somebody else drinking, so you want to take a drink, or you get nervous, and so your mouth dries up and you want to take a drink. So dry pharyngeal mucous membranes, angiotensin 2, um, causes us to want to drink more fluids when it is secreted, and it increased plasma osmolality, which means that basically the blood gets more concentrated. So again, these are some ways. This is just another pictorial representation of how thirst mechanism is stimulated. So if we have a decreased volume of extracellular fluid and an increased osmolality of extracellular fluid, then we have osmoreceptors in the hypothalamic thirst center. We have decreased salivation, dry mouth, and so the person feels the need to drink. We absorb the water from the gastrointestinal tract, and it increases the volume of extracellular fluid, decreases the osmolality of extracellular fluid. Average output. So again, it's about the same as what intake is. We have urine is the majority of it, but there is quite a bit of fluid that can be lost through the lungs and through the skin. And please keep in mind that that is of the average healthy person. So that's not somebody who's having a lot of shortness of breath or difficulty breathing. That's not somebody who's having diaphoresis. This is just somebody who is sweating and losing fluids through their skin. This is, normal feces, not diarrhea. So the amounts that certain conditions can cause to be eliminated from the body can greatly increase. All right, I am going to stop right there for this particular video, and we will come back up talking about isotonic fluid volume deficit and isotonic fluid volume excess.